this is probably the easiest and most obvious for ABG interpretation, is the uncompensated acid-base balance states. So remember that normal pH is 7.35 to 7.45. The normal CO2 is 35 to 45 millimeters of mercury. The normal bicarb is 22 to 24 millimoles per liter. Those are our normal values. Remember that acidosis in general, when we talk about all of these, acidosis or acidemias are more commonly identified in critically ill patients than you would see alkalosis. So you're more likely going to see acidosis or acidemia in these critically ill patients than you will ever see alkalosis in these critically ill patients. Once the pH falls below 7.2, there's several really significant effects that start to happen. Severe acidemia or headed towards that severe acidemia can definitely cause hypotension, can decrease your cardiac output, causes changes in the insulin resistance, can lead to hyperkalemia, can lead to other metabolic changes as well. It also alters the respiratory drive because, as we said, the lungs are going to kind of try to control how much acid is being produced and how much acid is being resorbed. So you're going to see patients start to get tachypnic because they're going to try to blow off all that extra carbon dioxide and try to, by blowing off the carbon dioxide, they're going to try to make it more of a neutral state, depending on where the acidosis is coming from. Remember, though, that the increased respiratory drive could lead to muscle fatigue and weakness. And then, because of that muscle fatigue weakness, specifically the diaphragmatic muscle fatigue and the weakness of the diaphragm, that could lead to the need for mechanical ventilation. Or if somebody is on mechanical ventilation and they're in an acidotic state, especially a severe acidotic state, they're not going to be able to come off that mechanical ventilation as well. Also think that acidotic states also affect coagulation. Coagulation is less active or just doesn't happen at all during severe acidemia, so it's harder to achieve hemostasis and can trigger some bleeding events. And if you think about it from a trauma perspective, which is my background, of course, you're thinking that trauma triad of death, which acidemia is one of the factors in the trauma triad of death. Then when we think about alkalosis, again, alkalosis or the resultant alkalemia that occurs from the alkalosis type process is going to be less common in the critically ill patient, but if it is present, once that pH value gets greater than about 7.6, we're worried about some adverse effects that are going to be coming from that. We can see some neurologic changes, which can lead to seizures. They can get hypokalemic because now the body's going to be trying to hold on to more acid. It holds on to more CO2 through the lungs. So we get some respiratory depression that is going to do that. It can also insinuate some dysrhythmias as well. So we need to keep our eye on those things if the pH value gets above that 7.6. Even with a mild alkalosis, you can see some respiratory depression start to ensue when you have a mild alkalotic state because the body's automatically trying to hold on to more CO2. So you can see some mild respiratory depression even in lower alkalosis type states. Again, that could result in the need for mechanical ventilation or decrease the ability for us to get the patient off of the ventilator in general. Just keep those concepts in mind. So when we're interpreting the ABG, obviously the first thing that we're always looking at is the pH. Where are we as far as the pH? Are we on the alkalosis side or are we on the acidotic side? And with the acidotic side, we said that acidosis and acidemia is more common in the critically ill patient. So we think we have two main categories that are then broken down, right? We have metabolic disorders and we have respiratory disorders. And then each one is broken down to metabolic acidosis processes or metabolic acidemia diagnosis, metabolic alkalosis processes or metabolic alkalemia. And then in the respiratory side, same thing, broken down into acidosis, acidemia, and respiratory alkalosis, alkalemia. So what do we expect to find in uncompensated states? And these are usually what we're going to be seeing and what we're going to be treating, because if they come in fully compensated, either it's a chronic disease that we're not really focusing on, they're just stable with that, or because the body is just really compensating really well for an underlying process, and eventually they're going to run into some trouble potentially. Let's talk about the acidosis acidemia side first. With both acidosis or acidemia sides, whether it's metabolic or respiratory, obviously first thing we're looking at is the pH, and we'll notice that the pH is low. pH is less than 7.35. Remember, once the pH gets lower than that 7.2, that's when we're really worried that something bad is going to happen because of all the things that we just talked about. So we look at the pH first, and we see the pH is less than 7.35. We either have a metabolic acidemia or a respiratory acidemia. And we have to figure out what is the underlying process, or what is the underlying respiratory or metabolic acidosis that is causing either the metabolic or respiratory acidemia. The second thing we should always look at, regardless of where our pH is and what we're thinking, is because CO2 really controls the acid and is the one that's going to correct really easily. Let's look at the CO2, because that's going to point us in the area of, is this acidemia respiratory or metabolic? And it makes us understand it a lot quicker. So we go to the pH, we see the pH is less than 7.35. Then we're moving on, we're going to evaluate our CO2. And we're going to find in a metabolic acidemia state, or in a metabolic acidosis process, the CO2 is probably going to be normal in an uncompensated state. Where in respiratory acidosis process, or respiratory acidemia diagnosis, the CO2 is going to be increased. We're retaining more CO2, and for whatever reason that might be, and we can talk about reasons for that later. And then we look at the bicarb and we determine, is there any compensation going on? Well, in an uncompensated state, you would not, in a critically ill state, you wouldn't expect any compensation to be occurring right away. So in a metabolic acidosis or acidemia, you would find a low bicarb, where in a respiratory acidosis acidemia, you would find a normal bicarb. And what those are telling me is then, when you compare the CO2 and the bicarb, if one is normal and one is abnormal, then whatever the state is that you're identifying is an uncompensated state. Same thing with the metabolic side. Metabolic alkalosis / alkalemia and respiratory alkalosis / alkalemia. First thing, again, we're going to look at is the pH. When we look at that pH and we see that's greater than 7.45, we know that we have an alkalosis process going on. We're going to look at the CO2 next. If the CO2 is normal, then we know it's probably not respiratory related. If the CO2 is down, we know it is probably respiratory related. So that means we have a metabolic alkalemia if we have that high pH with the normal CO2, respiratory alkalemia if we have that high pH with the lower CO2. And then again, we look at the bicarb for compensation. Metabolic alkalemia, we're going to see a increase in the bicarb with a normal CO2 and an increased pH. With the respiratory alkalemia, we're going to see a normal bicarb with an increase in the pH and a decrease in the CO2. So again, when we're looking at these and putting it all together, we have that alkalemic state greater than 7.45. If the CO2 is normal and the bicarb is elevated, it's an uncompensated metabolic alkalemia or alkalosis process. If the pH is high, greater than 7.45, the CO2 is low, and the bicarb is normal, then we know we have an uncompensated respiratory alkalosis or alkalemia. So it gives us an idea of what we're going to, and then we should be starting to think about what are the possible causes and the possible underlying features of what we're going to be diagnosing and treating as the causes of this alkalemic state. In general, maintaining a normal pH, changes in PCO2, so a change in by 10 of your PCO2. So if your PCO2 goes up by 10, requires a change in your bicarb of about 3 to 5. So for every 10 increase or decrease in your CO2, your bicarb should then change about 3 to 5. And that's how we maintain normal acid-base balance. If it's a metabolic state, for every increase in your bicarb by 10, your PCO2 should change about 15 to 20. So for every increase or decrease of 10 in the bicarb, there should be a change in the opposite direction of your PCO2 by 15 to 20 points. And that's how they maintain a normal state. If they can't do that, then what happens is you end up in these uncompensated states.